what I want to do today is actually capture the topics that I found that were incorrectly coded by the majority of you all. When we're coding for cerebrovascular accidents, we want to think about it when we're looking at the patient's chart. We want to be able to identify if it's an acute stroke or if it's a previous stroke. Your physicians a lot of times document history of or previous. They don't document the words in our code book. So we have to learn how to read that chart and interpret what we need for coding purposes. So we're going to look at each one in this category. And the first one is acute stroke, also referred to as cerebral infarction and cerebrovascular accident. When it is acute, it's coded from the I-63 category. Now, in your coding guidelines, we're told to use an additional code if known to indicate the National Institute Stroke Scale. That's from an R29 category. And yes, that is a symptom category. But when your coding instructions tell you to code from a symptom, then that bypasses the guideline that we do not code symptoms. Your guideline, these guidelines, conventions take precedence, okay? And I wanted to show you, I actually pulled it up on my other screen. So I wanted to show you what the R29 category looks like. They're going to give you, it's a scale or a score, and it's going to range from these categories. And honestly, you won't see this often because you're going to be in outpatient coding. But if you do, if you see it in the emergency department, if you're coding ER records, then you want to make sure that you assign the appropriate code. And you find those instructional notes at your I-63 category. So there again, you've got to remember to scroll down and find a code for those inclusions, exclusions, use additional codes, because those notes is where you're going to find that R29. And there again, it's a symptom. But those inclusion notes take precedence over the fact that we are told in the overall guidelines not to code symptoms when there is a definitive diagnosis. So you want to pay attention. I gave an example here. Patient is diagnosed with cerebral infarction due to embolism of the right anterior cerebral artery. That's going to code to I-63.421. What you can do when you get when you get the recording, is you can actually sit down and work through this with Find a Code and kind of make sure that you get it. And if there's any questions, then you know to send them to me. The next condition that we'll see in our charts is Sequela of Cva. That's late effects. That's residuals due to a previous stroke. They are always coded with your I-69 category. They will never be coded with I-63. So you don't want to get these two confused. There again, in the chart, the physician's not going to say, we have a sequela of CVA. They don't talk like that. This is ICD-10 coding. And that's why we as coders have to understand what our chart is saying to us. So here's an example. The provider documents right-sided weakness due to previous cerebral infarction in a right-handed individual and that is coded as I-69.351, hemiplegia and hemiparesis following cerebral infarction affecting the right dominant side. So there again, that provider, previous cerebral infarction, he may say, usually it's history of, and that throws you off, because when you see history of, you may think to go to the category history of. But if you have a residual, meaning a late effect, hemiparesis, difficulty swallowing, difficulty talking, if there's any residual late effect from a previous stroke, you will always assign from the I-69 category. Okay, let's look at the next slide. I'm going to do a little backwards here because I want to go ahead and address this, because we just talked about history of CVA. Right here, if you have a history of a TIA, transient ischemic attack, or if that chart has a history of CVA and there are no late effects, no residuals, it's a Z86.73 code. It will not come from I-69. I-69 is only assigned when there's a residual. So you really want to make note of that, because you're going to see that. You're going to see it in the chart at the physician's office. You're going to see it in the ED. So I want you to understand that guideline. Let's talk about the patient comes in the ED, and a lot of these, they're just not going to be physician office. But if you're an emergency room coder, that patient comes in, he has a current cerebrovascular accident, and he also has a sequela of a previous. You're going to have a code from your I-63 and your I-69 category. Example, the provider documents cerebral infarction due to thrombosis of left carotid artery and dysphagia following a previous stroke. Cerebral, you're going to assign I-63.032 cerebral artery due to thrombosis of the left carotid artery, and assign I-69.321 for the dysphagia following the previous stroke. Okay, so he's having a current and he's had a previous. So at that time, you would assign both codes, a code from each category. I made these notes because I want you to do this between now and your final exam, but I want you to do this for your job, for when you're employed, because these can be very confusing guidelines. So it's a good idea to take these and look at these guidelines in your code book, in your code finder. When you find these codes, I want you to read through the inclusions, the exclusions, the code also, all the instructional notes. And then I want you to read the common language description. I want you to understand these diagnoses. They are very common. So in your official coding guidelines, Chapter 9, this is A, B, C, D, and E. All this is captured in these. So just make a note, look through these, practice and find a code, coding these and becoming familiar. This one right here, this coronary artery disease with angina, you got a combo code. So you want to really pay attention.